All right, I think we're set up here. Hello, Brunswick County and beyond. Dr. James here with Coastal Integrative Health here in Charlotte, North Carolina. And I've got us on Facebook and on YouTube here, so you're able to watch us on either one of those streaming platforms here. And so what I had planned for us here today was really just doing kind of a Ask Me Anything, frequently asked questions that I get here in the office. So I've gotten a few email responses from patients, and then just frequently asked questions that I've gotten in the office here as well. So without further ado, we'll probably just get right into it here then. So one of the first questions that I ended up getting was, when should I seek chiropractic or physical therapy versus surgery? So obviously a very common question that we'll get. And with that, my theory is always we want to go up the food chain. So starting off more conservatively first before we get into things that are more irreversible, surgery, for example. And more often than not, we're even seeing surgeons such as orthopedists, even the American Academy of Orthopedists, where they're recommending for a lot of degenerative issues, not necessarily not necessarily trauma, but degenerative issues, starting off conservatively with that first. And so chiropractic, physical therapy, they fall right in line with that. So essentially, if it's essentially a joint issue, a neurological issue, sciatica, arm pain, carpal tunnel, headaches, low back pain, mid back pain, shoulder pain, we want to be starting off conservatively first. And another question that I got somewhat related to that as well: what is the difference between physical therapy and chiropractic? Obviously, with chiropractic, we're focusing more on the adjustments and mobilizing a lot of these tissues, a lot of soft tissue mobilization, so massage, ART, lots of different massage techniques that we're going to focus in on. Where with physical therapy, it's especially strengthening and stabilizing is always kind of my adage that I'll say with physical therapy. So we're kind of two sides of the same coin, where with chiropractic, we're really getting into mobilizing and diminishing the inflammation and pain that's going on. Physical therapy, it's going to be the strengthening and coordination. And then with that improved strength, we're going to see that precipitous decrease in a lot of the pain that's there. Now, not to kind of pat myself on the back there, usually with chiropractic, we can usually find patients will respond quicker with that as far as getting their pain levels down. And then even when we look at efficacy, as far as improvement in function, improvement in pain levels, we'll see with physical therapy, it's on average, I think the lowest that I've ever seen is about 70% improvement over the course of like 1 to 2 months, where with chiropractic over that same time frame, it's closer to like low 80s, 83%, I think is typically the average that I'll see. However, if we combine the two, we'll see upwards of low 90%, so about 93% effectiveness whenever we're combining the two together. So whenever we can, if we can ever combine those therapies together, that's where we're going to really maximize our improvement. And aside from the pat on the back there of beating out physical therapy, it's always a competition between us, basically. But whenever we compare either one with kind of the standard of care with medications, kind of the wait and see mentality. I mean, with medications, I've seen improvement as little as like 4% over the course of a month. We can see short-term improvement with medication. So I would almost use that as more of a stopgap to get us to more of these functional improvements with chiropractic or physical therapy. But rarely am I using it on its own because it just won't have that long-term improvement. We're just masking the symptoms. We're not actually taking care of what the root cause of the issue is for us. So getting into the chiropractic and physical therapy will yield better results for us more long-term. Now, another question that I've gotten from one of our patients is, can I still get chiropractic after I've had surgery? Particularly what they meant was more fusion. So they had a neck fusion, but this applies to patients with low back fusion or discectomies, hemilaminectomies where they remove a portion of the spine. I've had patients with Harrington rods as well, where they fuse pretty much the entire mid back there for scoliosis. So these are pretty drastic surgeries that patients have had, and they could still get chiropractic. even despite what even maybe their surgeon tells them, it's a matter of maybe switching what we would end up doing with that patient. And I would even argue for a lot of these patients that have had surgery, particularly fusion, it's almost more vital that they get that physical, or that they get physical therapy, or continuing the chiropractic more long term. Because what we'll end up seeing with fusion is that it starts to wear out the spaces above and below where that fusion was done, and then we'll just see exacerbation of these degenerative issues and disc herniations that develop above and below. So then it becomes almost this cascade effect of where it's just continuous surgery down the road. And we want to avoid that. So with chiropractic, we could find that we can potentially offset that furthering degeneration that would come in post-surgery. But yeah, it's just a matter of switching up how we would adjust, whether it's just purely the traction adjustments that we do here, what's called flexion distraction, utilizing something called activator, which it's just this kind of spring-loaded mechanism to do an adjustment along the spine. And even to some degree, we could still do hands-on manipulation, but obviously at the level of where it's fused, we're not doing anything to that area. So rarely have I seen any issues develop from where the surgery is performed, but if it is, then I have to look at other options for us, whether it be laser therapy, acupuncture, or dry needling, or even like the manual therapy to that area to try and soothe those nerves a little bit more. Chiropractic is still an option for us post-surgery. It's just we have to change up how we're doing it. Now, another question that I get very frequently, and what I hear from physical therapists as well, is if I'm still having pain with doing my home exercises, should I keep pushing through them? Now, there's a lot of different mentalities to this. My mentality is the idea of no pain, no gain. It doesn't necessarily hold true for a lot of patients. I'm actually focusing more in on, okay, you should feel a stretch. Maybe it feels like you're almost kind of exercising a bruised muscle or moving a muscle that you had just worked out. But as far as like pain, sharp pain, usually if we're getting something that's a little bit more intense and it becomes really uncomfortable, more often than not, I'm finding, okay, we don't necessarily want to push through that per se, because that's telling me that something is wrong with what's going on. And the idea of pain, it's there as that kind of warning siren that something's wrong, that we need to change what we're doing. Otherwise, we can end up causing injury there as well. So we just need to either alter those exercises or back down on how intense of a stretch that we're getting out of them. We should always feel a stretch before we get any pain out of it there. So either backing down on how far that you're pulling that stretch, so that way it's not painful and you're just getting a stretch out of it, or changing up the exercise completely. So that would be more of a specific question for our physical therapists or for whichever chiropractor that you're seeing here to correct those exercises then. Now, I ended up getting a lot of questions as far as do we do this? Do we do that? Can we work on this kind of questions? And one of the other common ones that I get is, can we help with TMJ issues? And it's always prefaced with something along the lines of, I know you're just a chiropractor, so this probably isn't what you deal with, but do you deal with the jaw at all? It's like, yeah, I deal with the jaw very frequently. And there's the automated lights here. There we go. Thought I'd have more than 10 minutes here. So with TMJ, what we end up seeing is there's a deep connection between that and the upper part of the neck. So we'll see headaches going alongside with TMJ issues. And they'll kind of feed into each other, where the back of the head can feed into jaw issues, but then the jaw will also feed into neck issues there as well. And it's just a lot of the pain receptors, they're actually kind of housed in the upper part of the neck there. So I think that's where some of that spillover comes into play. So it's either kind of tricking one or the other, that the other is also a problem as well. So oftentimes with TMJ issues, when we're working with dentists or orthodontists or maxillofacial surgeons, working hand in hand with those physicians, that's where we're probably going to yield the best results. But ultimately, yeah, I've dealt with a lot of TMJ issues. Usually it's either massaging the muscles on the outside of the jaw, the masseter muscle in particular. It's the biggest kind of muscular aspect for that jaw. But then probably at least a third of the time, I'm seeing more of the pterygoid muscles, which are on the inside of the mouth, right along that jawline. connecting the top of the skull to the inside of the jaw, and it's usually causing the side-to-side sway of the actual jaw, the mandible. Either when it opens, rather than opening kind of straight on, it kind of zigzags a little bit, or it kafunks off to one side. So if that's you, give us a call. We could probably help out with that. And then the other issue that I'll tend to see too is as that jaw is sliding forward or opening, actually kind of hinging forward, it's meant to slide forward right at that very end. So the pterygoids to help out with that slide forward to give you that last little opening there. There's a disc that's actually in the TMJ at the top of that, at the top of the mandible. As it's coming up through there, this disc is meant to kind of slide around. So sometimes it gets caught in there and then it slides, and then that's painful as well. So oftentimes it's either tractioning the jaw, working on these muscles. We're actually even just straight on adjusting the jaw in certain situations as well. Again, it comes down to what your particular exam is, what's causing those deficits, and then figuring out the best treatment option for you. So a lot of our treatment, it's not necessarily, oh, we're just going to be doing this, and then you're pretty much good to go. It's going to be different from person to person to figure out what is going on. And so we got a question here. I have pain in my lower leg around the tibia and fibula very often. Any suggestions? And again, with that one, with pain down through there, so we would end up having to figure out, okay, is that more of a knee pain? Is that neurological? Is it sciatica coming from the lower back? If it's just in the knee, likely it would end up being more of knee exercises that we'd want to focus on. So depending on your age, what's going on, looking at either something called wall squats to help strengthen up the knee, if it's right around like the kneecap, short arc exercises to help strengthen the knee if we can't do wall squats. And if it's going down the side of that leg there as well, what are called peroneal stretches or peroneal nerve flosses. So below the knee and teenager. So yeah, so if it's more of along the lines of like shin splints, if it's happening with running, getting into some specifics as far as a lot of these conditions, that's where it gets almost more into the examination style here. Yeah, and very high sitting for hours for her as well. So, and with that, that's where the examination is going to come into play as far as what is giving us more of the pain that's below the knee. It could be more vascular. It could be still more of tendonitis there as well. But if it's more with sedentary activities, I would actually probably consider more of following up with the medical doctor first to evaluate if there's any blood clot issues that are going on. You're kind of young for it, but there's even still medications out there that can maybe bring it on as well. So first question first thing that I'd want to do is more of an examination. And that's where either your medical doctor or another physician that's in your area there as well to be able to take a look at it, find what's going on. If it's more muscular skeletal, then we'd look at more of exercises for it, but we'd want to rule out anything that's more vascular first. Rule out the more severe stuff before we get into just muscular skeletal. So it's kind of hard to diagnose issues over the internet like this. So yeah. And then a few other questions that I'd gotten here as well. A few patients have also asked me about what is a short leg? What causes a short leg? So it's a common thing that we'll see chiropractors deal with, and they'll maybe just put it out flippantly. And so they're like, yeah, my other chiropractor has told me that I've got like one leg that's shorter than the other. What's causing that exactly? And it's about 80-90% of the people out there are going to have a functional short leg. So it's not necessarily that one leg is anatomically shorter where a leg bone is shorter. It's still possible that could be the case, but more often than not, we have what's called a functional short leg. So it's where in the pelvis, we'll see these the pelvic bones actually being kind of twisted up. And if we're looking at the pelvis, if these are the hips, I'm looking at the pelvis and we have it twisted. We have one hip that's actually looking shorter. So that ends up kind of dropping us down. And then we have this kind of lopsided gait, and it contributes to back pain that goes on, hip pain, knee pain, ankle pain there as well. So even evaluating those. Now, So with the short leg, most often what we're dealing with is a functional short leg. So that's where our adjustments using either like a drop table, doing where we do our side adjustments, where a patient's on their side to adjust their pelvis and their lower back, or even using that activator that I showed earlier here to help correct this functional short leg. Now, another option, like I alluded to, was an anatomical short leg. Typically, what I'll end up seeing with this is it was a childhood fracture. So they fractured their ankle, their knee, or hip in their youth, and it didn't heal appropriately. So while they were still growing in their more teenage years during a growth spurt, an area that deals with a fracture at a growth plate, that's not going to be growing anymore. It actually stops its growing. So that's where we'll see this bigger discrepancy that develops. And oftentimes when I'm seeing an anatomical leg, like the leg length discrepancy, it almost looks like it's a full inch to 2 inches off. It's very significant compared to what I'm seeing. It's usually functional. Whenever I'm comparing it, it's usually maybe a quarter inch, half inch. Maybe if I'm dealing with an acute spasm, I'll see up to an inch, but it resolves very quickly after that pain level drops down for us. But when I'm seeing it's a chronic pain, it's achy, it's dull, not really dealing with the muscle spasm, and it's 2 inches off, okay, what's causing that? So scoliosis and those old fractures, those are probably my biggest contributors. And that's actually just an easy fix as far as, it doesn't sound very good, but like a platform shoe. So you're actually building it up externally to help balance us out. So that's almost more of a podiatrist referral to get us the best care as far as these anatomical deficiencies. Now, one thing that I've also seen, and I don't really have a great term for it, so I just kind of term it more of a hybrid, are patients that are post-surgical, especially for like hip or knee. And then after that surgery, that's where we see the discrepancy that appears. Now, I would say, especially since probably like 2000, 2005 or so, most orthopedists are actually leveling out the legs whenever they're doing the surgery. And one question that I always kind of think of is if somebody is chronically short on one side functionally, like half inch short, and then they go to get the surgery and the surgeon's like, okay, we need to balance this out. So now anatomically they're in alignment, but their body's not used to it. And then all of a sudden afterwards, that's where they develop that pain. I wonder if now that contributes to it. I don't have a great answer for it, but I kind of wonder about that now. If our habits before surgery and after surgery. So weighing our options there. Just more food for thought, I guess, and not necessarily a big answer there. Now, I did kind of allude to one of my patients was asking me, what is the activator? Never did a video on it, so just kind of a quick primer on it here as well. So the activator, it's just a spring-loaded mechanism that we can change how much intensity goes into the adjustment. So something like that would be more so for the hip and lower back. Whereas if I'm doing the neck, I can end up bringing this down quite a bit and getting a much kind of finer adjustment out of it. So it's excellent for patients that are more apprehensive with more of the hands-on adjustments, that are either extremely sensitive, what they develop after an adjustment, what I have termed more of like a volitional response, where they just feel queasy, or it just really lights up their symptoms too much, more than what we would expect. Really rare for it to happen, but not unheard of. So that's where, okay, we alter our adjustment to make it more comfortable and get us the improvement that we're looking for. So it's just a tool that we can utilize that keeps the patient in a neutral position rather than having to have turn their head and then adjust through it to get that additional motion. Much more of a comfortable way for us to achieve the results that we're looking for. Now, another one, just kind of falling in line with that as well. Patients were asking me in the past more so about like the drop table. So I'm not going to drag in a chiropractic table here. I've got something that's pretty analogous to it called the Thule table. So using this more so for like the ankle, for the knee, to help adjust it, to help untwist the knee or kind of mobilize it if it's more arthritic. So just a gentle way to do it, but same concept as what I would do for the spine, where it has this, I'll turn it this way here, has more of this kind of drop mechanism here, where if you pop it up, it brings it up with this little kind of plunger that's underneath of the table here. Maybe you can see it on Facebook here. There we go. And then whenever you push down, it drops down. And it's kind of like the the saying, it's not the fall that kills you, it's a sudden stop. That's what ends up going on with this as well. It's not really how much pressure that we put in to do the adjustment. It's making sure that we have just enough to where that table will drop down, and then we keep pushing through once that table stops moving and it's hitting that flat surface here. So that's another way for us to do a good mobilization of that lower back, of the mid back, or extremities that I use that smaller Thule table for. And then, well, and I also had quite a few other questions of what kind of other patients are we able to see? And more often than not, if you're asking me, can we see these types of patients? Can we see these types of conditions? Yeah, it's typically that's the answer. So do we work on children? Yes. Do we see elderly people? Yes. So we could see people from minutes, well, maybe not necessarily minutes. They're not going to be making it to our office minutes old, but days old to the century old, basically. So we could see pretty much everybody in between there. And now it's not for me to say that every single person is going to get improvement out of what we'll do, but we can help out pretty much anything out there, if not resolve it. And with about 95% satisfaction rate with our patients, we're going to see that. So yeah, we'll see children, we'll see elderly, and we'll see pregnant patients as well. Now, each one of these categories, pediatrics, geriatrics, and pregnancy, they all require their own different touch. And this is what I kind of alluded to earlier, where patients can still have kind of the same complaint of neck pain, but how we're going to treat it will be different from age group to age group, condition to condition, and exam to exam. So with children, I mean, like with my son, for example, when he was born, I probably didn't adjust him for the first 2 weeks just because I was just focused on making sure that he was staying alive. So with that, I probably didn't get around to adjusting him until he was about 2 weeks old. And with that, if I remember right, I think it was more of a mid-back adjustment that I did on him. Just kind of was holding him in my lap and then just kind of squeezed a little bit and got his whole mid-back to just kind of rattle, basically. He enjoyed it, and we kind of stuck with it ever since. So with children, what we'll probably see most commonly nationally is more of colic types of issues. And I'll usually find with colic issues, it's going to be more mid-back adjustments for young children. So getting them back to sleep, less discomfort, less irritation. And then probably me personally with children, what I've seen are more of what look like ear infections, but not really ear infections. And before I get too long, hi, Nicole. And so oftentimes what we'll see with children with chronic recurring ear infections is they'll get on the medications, might resolve, but then comes back within a month, basically. And that's usually a sign for me is that it's more of a lymphatic issue that's going on, and oftentimes more of the spasm that's at the back of the head. And it's almost like a garden hose. It kind of squeezes it, all this back pressure, and then it causes this pressure that's inside the inner ear. So they'll feel the ear pain. They'll say that their ears can hurt, but then whenever I look in the ear using an otoscope, I'm not seeing any signs of infection. I'm not seeing fluid behind the ears. I'm not seeing redness in the eardrum or in the ear canal. Ear actually looks pretty dang good, but they're having the ear pain, and even me touching the ear doesn't really light it up. So we rule out a lot of the physical signs of infection, but they have the ear pain. And that's typically the most common patient that I'll see with this ear type of pain in a pediatric case. And they'll respond so well. And I forget the exact percentage of drops in surgery when a pediatric case of ear infections are coming in, but it drops it down by probably at least 3/4. And it's probably even higher than that. So if we're looking to prevent getting tubes in the ear, consider chiropractic. But even just with co-management, if there is infection that's going on, the adjustments should still help us out with it. But I still had patients where they do have the infection. It's like, hey, let's do the antibiotics. Let's go to your pediatrician. Let's go to your primary care, and and get the proper medication, and then we'll focus on the more mechanical aspects to kind of help facilitate that recovery and less of this rebound effect of a persisting ear infection. And then with elderly, again, it's going to just be changing up what type of adjustment that we're doing. So focusing on more of the flexion distraction, the traction adjustments here, because a lot of times with elderly, we're dealing with more of arthrosis, arthritis types of issues, stenosis types of issues. So we need to open up the spine and get things moving again. And oftentimes they're not going to be in the best situation to where getting them on their side to adjust them is going to be the best for them. And so even with those patients, the flexion distraction works out well. I've done another video on it on our YouTube channel that kind of highlights that flexion distraction. So I encourage you to see that. But there are still elderly patients that we can adjust. And with that one, it's going to be more of a lighter style of an adjustment anyways, too. And it just comes down to that line of drive. So I'll have patients where they're like, oh, yeah, you can really crank and yank me. It's like, we're moving millimeters. I'm not putting my whole body weight into any adjustment that I'm doing. So I can still adjust patients on their side. Just depends on the condition, basically. Then with pregnant patients, absolutely a necessity to get pregnant patients in for chiropractic. Just as baby's developing, mom is growing, ligaments are going to start to relax, and especially in that second trimester, bam, hits you like a Mack truck. And I'm sure, Nicole, you could probably speak to that as well. It's almost vital for pregnant patients to get chiropractic to kind of keep things in line with where they are, kind of maximize their pelvic positioning for when baby's growing, they kind of fall in the right position, and it makes delivery far easier with less complications as well. And again, just as mom's getting bigger, that might change up a little bit more of our plan there as well, as far as what type of adjustments that we're going to be doing with those patients. But still able to compensate for how mom's growing, how baby's growing. And then there's even Webster technique out there to, if a baby's in a poor position, like their breech or their transverse or any number of positions, we can kind of help spin that baby basically and get them in a better position as well. While I'm not actively certified in Webster technique, I've learned it quite a bit over the years. And for, I'd probably say at least 95% of the time, I get the result that I'm looking for with a lot of that manipulation of the womb, basically. And so additionally, one question that came up recently was, what is the difference between our objective improvement? We're looking at a report of findings that we had, and we had a goal of like 75% improvement, and they wanted 100%. It's like, okay, we want to get 100%. We always want to get close to 100%. And subjectively, that 100% is much more attainable. But for especially our patient population that we have down here that's more elderly and older, it's harder for us to get objectively 100% improvement. So we're always doing this little bit of a compromise. Now, I never like to see where objectively I'm seeing really great improvement. Subjectively, a patient's like, oh, no, I don't feel really good. It's I'm seeing 80% improvement and they're seeing 10%. It's like, okay, where is this disparity coming from? Then I have to do a little bit more of a workup and do a little bit more of a show and tell. It's like, okay, you couldn't touch your toes before. Now you can touch your toes and you can do it without pain now. Okay, we had sciatica that was going on. We had this abnormal sensation along this particular leg. You remember that? Yeah. It's like, okay, now I do it and it's totally equal on both sides. So we're seeing that improvement. So oftentimes where there's a disparity between subjective, objective, it's usually just kind of pointing out what we're seeing there to at least have them coincide and be talking appropriately, objectively and subjectively. But objectively, okay, with degeneration, I'm not going to see patients doing cartwheels if they are stenotic in the lower back. Now, another question that came across here, does chiropractic care help with older patients' gait? My mom has issues with one side balance-wise, and I wonder what's best to help for her. So, especially with gait issues, again, that's where it comes down to the examination to figure out where is the gait issue coming from. Is it because of arthritis in the hip? Is it coming from arthritis in the knee? Is it coming from like a neuropathy, a diabetic neuropathy, or vascular neuropathy, and they can't feel their feet, so now they're kind of more staggered in their gait. So oftentimes, especially if it's more mechanical, neurological, should be able to help out with it. If it's vascular, from the nutritional aspect that I handle, should be able to get some improvement with it, or using laser therapy as another option for if the gait issue is more of a sensory issue. And then if it's more of a weakness issue, that might be where doing the chiropractic in conjunction with the physical therapy would be worthwhile there. So ultimately, again, it's one of those things where I would say, yeah, we should be able to help out with it. To which degree, that's where I think the examination and actually talking about what is the problem is probably going to be more worthwhile in that situation, Stephanie. And then I've also been getting a lot of patients asking about our KMBO testing, the food allergy testing that we have, that we utilize here in the office, which really has been quite a lifesaver since I've come across it. Anytime that I'm dealing with a patient with just chronic pain, fibromyalgia types of issues, or just kind of wide-ranging kinds of gut issues, that's where I'll do this food allergy testing, where just comes with the whole kit of kind of lancets and a card, which I can't get out here right now. But basically, it's a finger prick test. Has a card that's in it that you end up putting drops of blood on each of these kind of circular discs, and then you'll mail it in yourself. They'll test that blood versus, I think it's 130 plus food items that are out there, and how your body responds to those food items, and if they are causing a delayed immune reaction. And these delayed immune reactions, they can cause wide-ranging symptoms as far as fatigue, chronic pain, depression, IBS issues, gut issues, diarrhea, constipation, reflux issues, hormonal issues as well, to some degree, if it's this chronic inflammation. And then I've also seen where patients have had with the inflammation for whatever food item that they're allergic to is so significant that it actually may have stemmed into causing a heart attack as well. Just as a bit of an anecdote with it, what I find really beneficial with these IgG tests, especially if they're a little bit more extensive, like I said, it's 130 food items, and I'll find at least one. There's always one of a food item that I would say for the general population, I'm like, that is a healthy food. It'd be fantastic for you. Keep doing it. But it comes back highly positive, and they have a severe reaction to it. And just with that chronic inflammation, what we ended up seeing with this one patient when I was up in Ohio still, she had an allergy to turmeric. Excellent anti-inflammatory. She was vegan or vegetarian. I forget which one she was. But then also a marathon runner. So she'd do a lot of 5Ks, 10Ks, and then marathons every so often. Suffered a heart attack. Doctors were like, we have no idea what caused this heart attack. They ended up doing cholesterol. Gorgeous. No problem. They did CBCs. They did CMPs. They just did the whole gamut on her. And everything came back fine. They're like, we don't know what did it. And they just put her on baby aspirin, basically, after she had recovered. And she ended up bringing this up, and we were like, as far as that heart attack, let's see if we could find out what might have done it. We ended up running a CRP, which tests inflammation in the blood, and extremely high. More or less, it's on like a 1 to 100 scale. It can go higher than 100, but you never want to see over 100. But ideally, you want to be 10 or less on this CRP scale. And she was, if I remember correctly, 68, 78, something along those lines there. So ridiculously high. It's like your blood is extremely inflamed, and that's what probably caused this heart attack. Just caused a lot of that inflammation, blood vessel damage, and then that blood vessel damage ended up going to the heart, causing the heart attack. And for us to try and figure it out, that's where we ended up using this IgG testing. And she came back highly positive to turmeric, which she was taking for inflammation because she was a runner. She's like, oh, I want to keep my joints feeling good. And so she was taking that. Now, despite this, even though she was a marathon runner and she had the heart attack, she was just having chronic pain kind of all over. And we saw that the turmeric was really high. She had something else that was fairly high, but probably the biggest thing that we took her off of was her turmeric supplement. And within a week, pain's pretty much gone. And then I think we I think it was a month or 2 months later, we retested that CRP after she was off of all these foods, and it went back down to like 8 or so, something like that. It just dropped down significantly, and that was just with purely the getting off of these foods that were or that she was allergic to. Now, as far as the cost of the food allergy testing, there's with KMBO, they've got 2 different ones. One tests, I believe it's 22 of the most commonly positive ones, and that one's around $100, $125 if I remember correctly. And then the larger one that I tend to like is closer to about $350. And insurance usually doesn't cover it. Sometimes HSAs may cover it. Since it's your own money, you can end up, I think, doing it as like either it's a durable medical equipment or it's like a nutritional supplement is what it's kind of treated as. So usually HSA is going to end up covering it, but out-of-pocket costs is where that comes into play. And I'll usually recommend the larger one just because the most common one, like I said, it's looking at gluten, it's looking at corn, soy, and about 19 other food items there as well. But as far as these herbs and a few of these other aspects that I would generally regard as really healthy, that I've had come back positive, whether it's garlic, turmeric, I've had like salmon coming back positive, I've had avocados coming back positive, and I've had some patients with like beef issues, and things that I would just generally say are good. They're covered on the larger one, but not necessarily on the smaller Fit 22. So only in certain situations, if we already kind of know what a food allergy is like, am I recommending that Fit 22? But more often than not, I'm recommending the full test, which, like I said, is about $350. But then, so not only are you getting the allergy testing with the larger one, but they also do a meal plan assessment as well. Like what should you have to eat for, I think it's over the course of a week. Breakfast, lunch, and dinner with 2 snacks in the day. They kind of give you an idea based off of what your allergic response is, what foods that you're having for each of these meals. And they try and mix it up pretty well too. So you get the nutritional consult and the larger test as well. All right. And then lastly, just in the last week, I had a patient ask me about exercises for scoliosis, which based off of all of our videos on YouTube, just kind of reviewing those, there's quite a few on there that would work out pretty well with scoliosis. But I think ultimately I'm going to have to do just a whole dedicated video to scoliosis just because it is going to be very specific to scoliosis, what I find works well for teenagers who most commonly I'm trying to proactively treat with scoliosis, and then the elderly, or more so just older adults where maybe arthritis is starting to settle in with the scoliosis to where I'm not going to be doing the same thing as what I was doing with a teenager, for example. And yeah. And since I've got you guys still on here, I think I ran through all the questions that I got through my email and in the office here. Oh, actually, I did get one more here today. Who would just me? It's like, I'm hunting over patients all day, and what do I do for my back? Well, me, I end up getting adjusted probably every like 4 to 6 weeks. Nicole, she probably remembers Dr. Craddock here, and he always had his spiel of, oh, if I go about 4 weeks, I could probably go a little bit longer. If 6 weeks for him was pretty much perfect. And he's like, and if I go about 8 weeks, I went a little bit too long. And I kind of fall into that same camp as well. So for me, I'm about 4 to 6 weeks. Just kind of depends on what's going on. I might get a proactive treatment if I'm dealing with like a headache one morning or something like that. But generally, yeah, full body adjustment every 4 to 6 weeks. Another question came in here. If you broke your ankle and it didn't heal right, can chiro help? Yes, more likely than not. So that's where just looking at how it looks after healing, likely if it's fairly soon after that fracture, we wouldn't really expect to see any arthritis that was there. So no necessarily any complications that'd be going on with it. With fractures or with ankle injuries like this, maybe adjusting it could work out. That's where the evaluation would come into play, updated x-rays if they're post-fracture, post-healing as well. And then my ace in the hole, I don't know about you, Nicole, with where you're at right now. but laser therapy, cold laser, works really well with a lot of these kind of old injuries like that as well. So that's another thing that I would utilize with good success. But even potentially even like kinesiotaping, if there's a lot of swelling that happens around it still, if you're kind of upright walking on it, even though it's healed, it's not moving properly. So kinesiotaping could also be another good option for you. And even those inexpensive braces that you'd find at the pharmacies and grocery stores to at least keep it wrapped to prevent any of that swelling, because oftentimes it's more of the swelling that's kind of restricting more of the motion. So that could potentially help us out. But then even come back to physical therapy as well. If you haven't had that, that would still be an option for us to strengthen up a lot of the soft tissue that's around that area. So yeah, as far as treatment options, chiropractic, physical therapy, kinesiotape, laser therapy, those are probably my best go-tos with an ankle injury like that. All right. Yeah. So I don't know about you guys, but I ended up having a lot of fun. So hopefully we can do it again. I'll probably stay on here for probably like another minute or so if there's any other questions here. But otherwise, you guys stay healthy. All right. No problem, Nicole. Yeah. You can always message me or call me up. I'm always happy to help out.